Good morning, everyone. This is Group 4, and we will be presenting our case number 2. General data. The patient is a 4-week-old female, and the chief complaint is a 1-week history of coughing and post-tussive vomiting. History of present illness. A 4-week-old previously healthy term baby girl was taken to the OPD with a 1-week history of coughing and post-tussive vomiting. Numerous episodes of central cyanosis and associated lethargy and respiratory distress had occurred after the coughing fits. While at the OPD, we were able to witness the coughing episodes. She was then brought to the ER for admission. In the patient's past history, the prenatal history of the mother revealed that she had irregular prenatal visits. Patient was born at CDUH via NSVD to an OB score of G1P0 to a 27-year-old single mother with no perinatal complications. In her postnatal history, she was given Hep B and BCG at birth. She is also purely breastfed. In her family medical history, it revealed that the patient has no history of asthma nor any heredofamilial diseases. On physical examination, the patient was irritable and not in respiratory distress in between bouts of coughing. Temperature was 36.5 degrees Celsius and she weighed 5 kilograms. There was flaring of Allen assay, and an examination of the chest and lungs revealed slight intercostal retractions with harsh breath sounds.
So the clinical impression is pertussis. For the basis, the patient had signs and symptoms of cough, post-tussive vomiting, episodes of central cyanosis, lethargy, and respiratory distress. The patient is 4 weeks old and hence not yet been vaccinated. In the history, it was mentioned that her mother had irregular prenatal care visits, and so the recommended vaccination at 27 to 30 weeks of pregnancy may not have been done. In the PE findings, patient was noted to be irritable, flaring of Alanaceae, and slight intercostal retraction with harsh breath sounds were noted. In the video, we saw that the patient held the chin and chest forward, tongue protrusion and watery eyes were also noted. For the etiology, gram-negative coxobacilli, Bordetella pertussis and Bordetella parapertussis are the non-causative agents. Bordetella pertussis is the main causative agent, and Bordetella parapertussis causes a milder form of the disease. The transmission is via aerosolized droplets. For the epidemiology, it is most commonly seen in young infants, and second highest incidence is seen in 10-year-old children. It is the most common vaccine-preventable disease in the US. Severe and fatal infection are seen in patients too young to be vaccinated, as seen in the case, but these patients are usually protected via maternal antibodies, and hence Tdap vaccination is recommended at 27 to 30 weeks of pregnancy. Neither the natural disease nor vaccination provides a complete or lifelong immunity.
For the pathogenesis of pertussis, Bordetella organisms are known to be small, fastidious gram-negative coccobacilli that colonize only ciliated epithelium. As of today, the exact mechanism of disease symptomatology remains to be unknown. Only the species Bordetella pertussis expresses pertussis toxin or PT, which is said to be the major virulence protein. This has proven to have numerous biological activities such as histamine sensitivity, insulin secretion, and leukocyte dysfunction. And PT appears to have a central but not a singular role in the pathogenesis of pertussis. After aerosol acquisition, filamentous hemagglutinin, some agglutinogens, especially your fimbriae types 2 and 3, and a 69 kilodalton non-fimbrial surface called your pertactin or your PRN are important for attachment to ciliated respiratory epithelial cells. And lastly, tracheal cytotoxin with adenylate cyclase and your pertussis toxin appears to inhibit clearance of organisms. And your tracheal cytotoxin plus your dermonecrotic factor and adenylate cyclase are said to be responsible for the local epithelial damage that produces respiratory symptoms and facilitates absorption of your pertussis toxin. So antibodies to your PT neutralizes the toxin. However, antibodies to your pertactin or your PRN enhances opsonophagocytosis. In general, pertussis is extremely contagious, with attack rates may be as high as 100% in susceptible individuals exposed to aerosol droplets. And pertussis does not survive for prolonged periods in the environment. And once after an intense exposure, such as in households, the rate of clinical infection may be as high as 80%, regardless if the person is already immunized or has been previously infected with the organism. For the clinical manifestations, well, classically, pertussis is said to be a prolonged disease, and it is divided into 3 stages. You have your catarrhal, paroxysmal, and your convalescent stage. So first, I would like to discuss the catarrhal stage, which usually occurs within 1 to 2 weeks. And this begins insidiously after an incubation period which ranges from 3 to 12 days. And here, there are non-distinctive symptoms of congestion and rhinorrhea, which may be accompanied by a low-grade fever, sneezing, lacrimation, and conjunctival suffusion. As initial symptoms wane, coughing marks the onset of the paroxysmal stage, which begins at weeks 2 to 6. The cough begins as a dry, intermittent, irritative hack and evolves into the inexorable paroxysms that are said to be the hallmark of pertussis. Sometimes a well-appearing, playful toddler with insignificant provocation suddenly expresses an anxious aura and clutches a parent before beginning a machine gun burst of uninterrupted cough on a single exhalation. Sometimes the chin and the chest is held forward, the tongue protruding maximally, the eyes bulging and watering, with the face turning purple, until the coughing ceases and a loud whoop follows as the inspired air traverses and still partially closed airway. Post-tussive emesis is common and exhaustion is universal among children. The number and severity of paroxysms escalate over days or weeks, and at the peak of the paroxysmal stage, the patients may have more than one episode hourly. Lastly, in the convalescent stage, which occurs at more than 2 weeks, the number, severity, and duration of the episodes diminishes. Lastly, as related to our case, infants younger than 3 months of age do not display the classic stages of catarrhal, paroxysmal, and convalescent stages. So the catarrhal phase here lasts only a few days or sometimes is unnoticed. And then a well-appearing young infant begins to choke, gasp, gag, and flail the extremities with face reddened. Here, the cough may not be prominent, especially in the early phase, and the whoop may be infrequent in infants younger than 3 months who at the end of the paroxysm may lack stature or muscular strength to create a negative intrathoracic pressure. Sometimes, apnea and cyanosis are more common with pertussis than other neonatal infection from viruses such as your RSV, and sometimes it can follow a coughing paroxysm. In some instances as well, apnea may only be the only symptom that can be seen. In the paroxysmal and convalescent stages in young infants are lengthy compared to the ones with more than 3 months of age, and the convalescent stages includes an intermittent paroxysmal coughing throughout the first year of life, which may also have exacerbations with subsequent respiratory illnesses that may sometimes be mistaken as a recurrent infection or reactivation of the pertussis. And the cough and whooping in this stage may become louder and more classic.
Differential diagnosis. We ruled in first the adenoviral respiratory infection because according to a case report from Istanbul, this infection can present with pertussis-like syndrome characterized by paroxysmal fits of coughing as manifested by our patient. This infection can also present with vomiting and respiratory distress. In addition to the symptoms reported, this infection is also common in children less than 5 years old. However, as stated in Nelson's, we ruled this out because of the absence of fever, sore throat, and conjunctivitis, all of which can distinguish adenoviral infection from pertussis. Second, we ruled in Mycoplasma pneumoniae caused by Mycoplasma pneumoniae. This is an important cause of community-acquired pneumonia in children and neonatal lower respiratory tract infections. Mycoplasmal pneumonia in neonates tend to be a milder process compared to older patients. Cough is also the most common symptoms of pneumonia with infants, which was presented by our patient. Associated symptoms such as lethargy, irritability, and respiratory distress are also presented by the patient. Signs of respiratory distress include flaring of Alanase, slight intercostal retractions, and harsh breath sounds. However, we ruled this out because Mycoplasma infection usually has a history of fever and other systemic symptoms at the onset of disease. Frequent finding of rales on chest auscultation is also absent.
Another atypical pneumonia that is one of our differentials is chlamydial pneumonia. It's compelling to believe since this is transmitted vertically and the mother did not have a good history of prenatal checkup. Furthermore, this has an incubation period of 3 to 4 weeks, which corresponds to the patient's age. Other reasons for ruling this in is a history of coughing, central cyanosis, lethargy, intercostal retractions, harsh breath sounds, and nasal flaring. Patient, however, did not exhibit what typifies chlamydial pneumonia, such as staccato cough, purulent conjunctivitis, and wheezing, so we ruled it out. Another interesting differential diagnosis is respiratory syncytial virus infection. We ruled it in because it is one of the leading causes of lower respiratory tract infections in infants and young children. In addition, history of coughing, central cyanosis, lethargy, respiratory distress, harsh breath sounds were also present. However, we ruled it out because usually there should be a predominant lower respiratory signs such as wheezing or rales. Besides, this infection progresses rather rapidly. Fever and tachypnea that characterizes this infection was not observed too. Of course, we did try considering that this might be a case of a febrile pneumonia syndrome, which is uncommon, but then patient did not have apnea, a major manifestation when fever is absent. Moreover, according to journals, for infants less than 6 weeks, RSV paints a nonspecific sepsis-like picture. Other two differential diagnoses that we thought of because they are common causes of acute cough was asthma and foreign body aspiration. We ruled it in for similar reasons such as coughing, central cyanosis, lethargy, respiratory distress, and intercostal retractions, except that post-tussive vomiting exclusive for asthma and for no complications at birth for foreign body aspiration. We ruled out asthma because there was no family history, although that is a little questionable because we do not know whether paternal history was also extracted. But then, wheezing is typical, which is typical of asthma, was not observed. Foreign body aspiration was ruled out because the patient was only 4 weeks old, so it was less likely for her to grab an object and bring to mouth.
For diagnostic management, pertussis should be suspected in any individual who has a pure or predominant complaint of cough, especially if the following features such as fever, malae or myalgia, exanthem or enanthem, sore throat, hoarseness, tachypnea, wheezes and rales are absent. For sporadic cases, a clinical case definition of cough of more than or equal to 14 days duration with at least one associated symptom of paroxysm, woof, or post-tussive vomiting has sensitivity of 81% and specificity of 58% for confirmation of pertussis. Pertussis should be suspected in older children whose cough illness is escalating at 7 to 10 days and whose coughing is not continuous but rather comes in bursts. And also, pertussis should be suspected in infant of less than 3 months old with gagging, gasping, apnea, cyanosis, or an apparent life-threatening event. Also, sudden infant death occasionally is caused by Bordetella pertussis. For laboratory findings, leukocytosis caused by absolute lymphocytosis is characteristic in the catarrhal stage and is correspond with disease severity. For chest radiographic findings, showing perihilar infiltrate or edema, sometimes with a butterfly appearance and variable atelectasis. Also other finding, parenchymal consolidation, which suggests secondary bacterial infection. And also other findings such as pneumothorax, pneumomediastinum, and subcutaneous emphysema can be seen occasionally. Methods for confirmation of infection by Bordetella pertussis include culture, PCR, and serology. For culture, a specimen is obtained by deep nasopharyngeal aspiration or with the use of flexible swab held in the posterior nasopharynx for 15 to 30 seconds or until cough occurs. A 1% Cas amino acid liquid is acceptable for holding a specimen up to 2 hours. Steiner or Scully broth or Regan-Lewis semi-solid transport medium is used for longer transport periods up to 4 days. The Regan-Lewis charcoal agar with 10% horse blood and 5 to 40 microgram per ml of cephalexin and Steiner Scully media with cyclodextrin resins are the preferred isolation media. Cultures are incubated at 35 to 37 degrees Celsius in a humid environment and examined daily for 7 days for slow-growing, tiny glistening colonies. For polymerase chain reaction testing on nasopharyngeal wash specimen is the laboratory test of choice for Bordetella pertussis identification. For serologic tests, direct fluorescent antibody testing of potential isolates using specific antibody for Bordetella pertussis and Bordetella parapertussis maximizes recovery rates. Serologic tests for detection of change in antibodies to Bordetella pertussis antigen between acute and convalescent samples are the most sensitive tests in immunized individuals and useful for epidemiologically. A single serum sample showing IgG antibody to PT of more than 90 IU per ml indicates recent symptomatic infection and usually is positive in the mid-paroxysmal phase.
For the therapeutic management of pertussis, most patients require hospitalization, especially in cases with infants less than 3 months with suspected pertussis, or premature born infants, or children with underlying cardiac, pulmonary, muscular, or neurologic disorders. So for the table presented in Nelson's Pediatrics 21st edition, it shows warnings in assessment and care of infants with pertussis. So this is a summarized table of the deciding factor whether a patient can be treated in the hospital or at home, the methods or observations done in the hospital during admission, and the aftercare of patients that includes family education, recruitment as partner of the team, and continued support after the patient has been discharged. So in continuation with the hospital admission, usually heart rate, respiratory rate, and pulse oximetry are continuously monitored with alarm systems to make sure that the paroxysms can be witnessed and recorded. And previously mentioned in the table, detailed cough records and documentation of feeding, vomiting, and weight change are recorded to assess the severity and progression of the illness. Also, it is important to assess the need to provide oxygen, stimulation, or suctioning by observing the infant's ability for self-rescue, but as well be prepared to intervene when necessary. Usually, large volume feedings are avoided, which can precipitate the paroxysmal cough, and patients with life-threatening complications usually require intubation and pharmaceutically induced paralysis.
And if a patient is likely to be discharged appropriately in the next 48 hours, this is because the disease severity has been unchanged or diminished. Intervention is not usually required during the paroxysms, and parents are prepared to care for them at home.
So for the antibiotics, azithromycin is the preferred agents in all age groups, and only rare cases of infantile hypertrophic pyloric stenosis have followed its use in neonates. All young infants treated with any macrolide should be monitored for symptoms of pyloric stenosis. The FDA also warns of risk of fatal heart rhythms with the use of azithromycin in patients already at risk for cardiovascular events, especially those with prolongation of QT interval. So this is a table from Nelson's, the recommended antimicrobial treatment and post-exposure prophylaxis for pertussis by age group. In our patient's case, we will use the azithromycin dosage of 10 mg per kilograms per day since the patient is already 4-week-old. The patient will receive 50 mg per day in a single dose for 5 days based on the weight and the recommended dosage of azithromycin for ages 1 to 5 months old. So patients with suspected pertussis are placed in isolation with droplet precautions. Begin isolation immediately and until 5 days after initiation of macrolide therapy. All healthcare workers should wear a mask upon entering the room. For close contacts, a macrolide agent should be given promptly to all household contacts and other close contacts. So the same drugs and age-related doses used for treatment are used for prophylaxis, as shown in the table earlier. In close contacts less than 7-year-old who have received fewer than 4 doses of pertussis-containing vaccines, DTaP should be initiated or continued. For those who have received third dose more than 6 months before exposure or fourth dose 3 years or more before exposure should receive a DTaP booster dose. Individuals 9 years of age or older should be given Tdap if they haven't received it previously.
The principal complications of pertussis are apnea, secondary infections like your otitis media and pneumonia, and physical sequelae of forceful coughing. Fever, tachypnea, or respiratory distress between paroxysms and absolute neutrophilia are clues to pneumonia. Expected pathogens include Staphylococcus aureus, Streptococcus pneumoniae, and bacteria of oropharyngeal flora. Increased intrathoracic and intra-abdominal pressure during coughing can result in conjunctival and scleral hemorrhage, petechiae on the upper body, epistaxis, pneumothorax and subcutaneous emphysema, umbilical or inguinal hernia, and rarely, hemorrhage in the central nervous system or retina. Progressive pulmonary hypertension in very young infants and secondary bacterial pneumonia are severe complications of pertussis and are the usual causes of death. The need for intensive care and mechanical ventilation usually is limited to infants less than 3 months old and children with underlying conditions. Respiratory failure from apnea may mandate intubation and ventilation through the days when disease peaks. Echocardiography should be performed in critically ill infants with pertussis to detect presence of pulmonary hypertension and to intervene expeditiously. Acute neurologic events during pertussis almost always are the result of hypoxemia or hemorrhage associated with coughing or apnea in young infants. Apnea or bradycardia or both may result from apparent laryngospasm or vagal stimulation just before a coughing episode, from obstruction during an episode, or from hypoxemia following an episode. The only neuropathology documented in pertussis is parenchymal hemorrhage and ischemic necrosis.
So for prevention, universal immunization of children with pertussis vaccine is essential to the control of pertussis. So we have 2 vaccines, your DTaP vaccine and your Tdap vaccine. DTaP vaccine is for children younger than 7 years of age, and we recommend giving 5 doses of this vaccine. So the first 4 doses should be given within the first 2 years of life, generally 2, 4, 6, and 15 to 18 months. And the 5th dose should be given within 4 to 6 years of age. So the next vaccine is your Tdap vaccine. Tdap vaccine is for children older than 7 years of age, and it is also given to adolescents and adults. So the preferred age for Tdap vaccination is 11 to 12 years old, and it is also given to pregnant women between 27 and 36 weeks of gestation to maximize antibody concentration at birth. So for those children who had incomplete DTaP vaccination before the age of 7, a single dose of Tdap vaccine is recommended. Also, for adolescents and adults of any age who have not received Tdap should also receive a single dose of Tdap regardless of interval since TD.